Yeah, my daughter didn't see that. I am surprised. Well, you know, I think it's why not? Well, commercials, that yeah, it's crazy. Everything is Hey there. How are you? I do that at times. You have one. Probably, like I said, we would, like 25 to 30 different opportunities. So, yeah. How are you? So they would just like but if you can like
Yeah, I mean, you can do that, and then we can, when you're done, you can stay here and we'll take some questions here. If everyone will take their seats, we'll get started. Yep. Try to stay on time.
Morning, everyone. Welcome to Chicago. Picked a nice day to be here, way better than some other parts of the country, I think. So I'm feeling pretty fortunate to be here today. So my name is Jim Sharan. As you can see by the slide, I am the Senior Director of Benefits for Molson Coors. Prior to that, I was the Director of Benefits for Miller Coors until we were purchased by Molson Coors. Uh-oh, we went one ahead here. I'm also the acting chair of NAWHC for the past couple of years. It's been my honor, as you can see from the slide. And the other thing you can see from the slide is never use a selfie. Profile. It's not a really good idea. So Larry let me peek at the slides for the intro, and I know the intro is 10 minutes, and I have this slide, and he's got 12. So that's kind of an indication of how much time I have. So again, I just want to do a shout out to the folks at Drinker Biddle and Mindy McBee at MVGH and the MVGH crew for helping make this, and of course all of you for attending and making this a success. So now it's been, what, 7 years now, Larry? 2012, so 7 years. You know, and it started out as an idea. I'm going to take like a minute, if that's okay. You know, it was an idea from Larry, and I think Mike LaPenna, Mike's here, I think I see, kind of the driving forces between the idea of the fact that, look, on-site healthcare is not just this thing for large employees or health systems. Really, it's got some legs, and people are using it in a lot of different ways in an attempt to deliver high-quality, lower-cost, efficient healthcare for their employees and their groups, right? But there was something lacking. And what that was kind of an organization. So everybody's got a coalition, right? We've got MVGH, there's the Pacific Healthcare Group, there's the Business Healthcare Group of Southeast Wisconsin, which I'm a part of, so we all have those types of things. There's RX collaboratives, there's all these things going on, but there was not an organization to bring the collective wisdom together of folks who have on-site clinics. So Mike and Larry put their brains together and created NAWHC. And 7 years later, here we are delivering what I think is huge value for members in terms of how do we make these things work? What works? What doesn't work? What's problematic? And that's what we're here to do. I served on the board for 2 years. It's a really smart bunch of people, and we get to sit around and talk about how to make these things better. And that's why we're here today. When I go to seminars or sessions like this, I say to myself, I want one good idea, and then it's worthwhile. I think when you come out of this today, if you looked at the agenda, you're going to come out with a variety of good ideas for those of you who have on-site clinics. And for those of you who are just thinking about it, again, you'll generate some great ideas. So again, thank you all for coming. I really appreciate it. And now I'll turn it over to Larry, who's got the rest of the show. Thanks, Larry.
Thank you, Jim.
Appreciate it.
It's a pleasure. So, again, I'm Larry Boris, Executive Director of the National Association of Worksite Health Centers. By the way, any Star Trek fans here? Anybody in the room? One in the back? Okay, question for you. What does NAWHC mean in Klingon? Right? My kids went to a Star Trek convention years ago, and I picked up a Klingon dictionary. And when we created the National Association, you know, you look at the anagram and say, well, what is that? And NAWHC, now, it sounds like Klingon. So I looked up the dictionary. NAWHC means access in Klingon. So you're now all officially Klingons, a part of our universe here. So NAWHC is a nonprofit, as Jim mentioned. It's the only organization of its kind in the country for employers, unions, other sponsors of on-site and near-site mobile units, pharmacy, fitness centers, focusing on how you can develop and how you can expand these. We have our own website, our own LinkedIn group, and we would strongly encourage you to participate. We are all inclusive of all stakeholders, though we are primarily what I would call purchaser organization, focusing on those who sponsor on-site and near-site centers. Benefits include networking. That's why we have roundtables. We don't have theater seats. We hope that you meet new people here, get engaged. We do benchmarking surveys, educational programs here and around the country. We have a resource library for members on our website. We're doing pilot programs. You'll hear about one shortly during lunch. We have a variety of updates on legal and regulatory issues, and we do provide staff support and purchasing support as well. Programs coming up, we join with other groups like the World Congress and Global Media, so there's a program just coming up later this next week in Atlanta. In Louisville, we have a program with the Kentuckiana Healthcare Coalition. We have a webinar with the American Heart Association on blood pressure. October 17th, we're joining a program with the National Association of Occupational Health Professionals. We then have a program out in Scottsdale with the Global Media, etc. And next year, we're going back to Milwaukee to the Harley-Davidson Museum for our annual forum in 2018. So we'll hope you'll join us out there. First, everybody not have a cell phone. Please put it on mute or on silent or vibrate. If you have an Android, the same thing. One thing, I would like everyone now, though, to take out your cell phone, and I want you to go to this website, pollev.com/NAWHC poll. We're going to have a series of questions for those both here and on the Internet, and you can answer it by your phone. And that's the only time we want you to pick up the phone. No texting, no emailing, but we do want you to take advantage of this. When you see on your phone a question, you just answer it on the phone and it'll show up on our screen. So again, it's pollev.com/NAWHC POLL. Okay? And when you see the questions on the screen, it'll have the same website address. And when you get to there, it'll probably say, welcome to the NAWHC polls. So, let's start out there. Who do you represent today? I want you to take a look at this and give us your thoughts. You see it on your phones? Is that a yes or no? Yes. Yes? Okay, great. And just click on that. And I'm going to change this in a second. That's not what I wanted to do. And it's not doing what I wanted to do here. Okay. This is a new feature we're trying today, and I can see it's not working for me. Okay. Okay, we're going to move along, because this is unfortunately not functioning the way I'd hoped it would. So we're going to skip these. Let me just ask you, raising your hands then. How many are employers in the room here? Okay. How many of you have clinics? Thank you. How many are looking at clinics and considering that? Great. Thank you very much. So this program is certified by HRCI. If you need advanced credit or certification credits, please go to the registration desk and we'll get a certificate for you. You can get information on these and other topics through NAWHC, through our website, or contact me directly. So what we're going to start out with is our first presentation will be by Mike LaPena and John Newberger from Quad Graphics. talking about why on-site clinics should be part of your benefit strategy. They've had 2 decades of experience and lessons, Quad Graphics being one of the first employers to really expand this for their population. Mike, being the leading expert on on-site clinics, actually has 2 books coming out on on-site clinics, and perhaps the only one that you'll find on your shelves. So as I set up their slides, please welcome Mike LaPerna and John Newberg. You want to walk, or are you going to stay?
Go right ahead and start us off.
Okay.
Thanks very much. Can everybody hear me if
No.
I stand out here, or?
For those on the internet.
My answer is no. If you're not in the room, and John and I'll trade off a little bit. I guess Larry will, I'll work on the board here so that.
All right. Here we go.
Got it. Thanks very much. Well, thanks very much to Larry. Thanks for Jim for his leadership. With Larry's energy and Jim's leadership, and with the experience and expertise of the board members, this has grown into a fine organization. The idea of on-site clinics started out a long, long time ago with company doctors, I suppose. And the thing that I'd mention is that it was an idea, an innovation, and then it became a trend with certain thought leaders in different industries adopting it and forming it. And now it's actually I guess a movement, because it's got lots of breadth and lots of stuff behind it. So you'll see brokers involved, hospitals, insurance companies, and you'll see Wall Street money and all sorts of stuff. So it's been a real change over the years, over the couple of decades we've been involved. And we appreciate the fact that if you're looking at an on-site clinic now, just as if you're looking at a new TV set now, you don't say, look, this is my first TV set. Where's the stuff with the cathode ray tubes, the big heavy stuff, the stuff that you and I know, if you take it to Goodwill, they won't take it from you, because they say it's old technology, it doesn't hook to anything. They'll say, but this is my first TV set. Shouldn't I start out with the cathode ray tube and then maybe move up later on to a remote, and maybe later on to digital, and maybe later on to, no, you don't. You jump into the technology where the technology is, and the technology has changed, only some of the firms don't yet know that, and some of the vendors don't yet know that, and some of the players in the industry don't yet know that. But anybody from this session is going to know this. And so as we take a look at this, we used old technology, John and I, and we asked the question, went back to the idea of, why your benefit strategy should include, well, do you even have a benefit strategy? If you don't know a benefit strategy and have it well planned out, then you won't know how to start with an on-site clinic. Do you have beneficiary satisfaction, access, cost sensitivity? It's not just cost. Are you deploying new technology? So you're looking at the new science of consumer involvement and population management. If your benefit strategy is one that includes all of these ideas, then the on-site clinic becomes part of it. The on-site clinic is not a benefit strategy, it's part of one. And do you manage the healthcare benefits dollars, or do all those factors out there manage your firm? That's the question. Other part of it that we thought of, John and I, and we were struggling over, just a couple of different things that we know now that when we were starting out we didn't know then. Stuff that we learned along the way or that emerged along the way. And again, this is over 20 years, because our firm started 25 years ago or 30 years ago as a consulting firm. We never did anything with on-site clinics or with employer-based clinic activity. That was all occupational health. We now know that on-site clinics aren't just clinics. John will go into this in some detail. The model is not necessarily an on-site on model. It doesn't have to be on. That's an erroneous word in there. Vendors are not vendors. We'll talk more about what vendors are in a moment, but I dislike that term, and we're trying to work that out of our vocabulary, because vendors, John will talk to you about how vendors are and how we perceive them now. The on-site clinic's not the place to start. This is secondary to the first slide, which said that the idea is that the benefit strategy is a place to start. Then you plan the clinic to be part of it and complement what else you're doing. And then honestly, when we first started out, you just started an on-site clinic and they always succeeded. Because they were novel and new, had no metric against which to judge them, but in the past 5 years, we've probably seen our firm, which is a small firm based in the Midwest, boutique firm, that means really tiny firm. Our firm has seen a dozen of these things fail. Fail and transition from one to another, fail and close, fail and reformat. So on-site clinics don't always succeed. Sometimes they fail. We're not going to talk about the healthcare system, the cost benefit of employer-managed health, how to plan the on-site program. All this stuff is available. You've got stuff on the NAWHC website, plethora of information, good stuff. We're not going to go back over that. So this is all about what's new, what's different, and what you should be planning in 2017 for use in 2027. What is new? On-site now a mature model. It's not an immature model. So if you go through your curve of product development, you're in a different space on this curve. Enter in at the 1080 number of lines at TV. That's the line count in high-def TV. That's already being replaced. I thought when I bought my TV set a couple of years ago I was okay. Now kids complain about it because they'll tell me the refresh rate isn't good enough for the Xbox. So what you've got to do is you've got to enter in at the new refresh rate. The idea is now mainstream, tremendous confusion in the market for healthcare services. You enter at a good time because if you have clarity, you're entering a market which has lack of clarity, confusion. That means opportunity for people who know what they're doing. So if you know what you're doing and you know where you're going and you enter into a confused marketplace with anxious and upset and on-the-edge providers, you're going to be able to craft a program that's absolutely suited to your needs. But don't enter into the fray, into the scrum. You'll enter in with some knowledge and some foresight and some planning, and you'll be able to take over your market position and make it work for your firm. New players, new partners, new forms are emerging. We'll talk a little bit about that. And the consumer, brand new now, in the last 5 or 6 years, is now hardwired into a connection between their pocketbook, their health, the prevention, and what's going on in the marketplace. It didn't used to be that way. I just go in, put down my card, maybe somebody charges me $7, or maybe I forget to pay and they never bill me. But now the whole concept of consumer participation is here. So we're hitting and working with beneficiary groups that are absolutely hardwired to their pocketbook and have a sense that when the employer assists them with access, improved value, a metric, they want to know that. An employer comes forward with a new idea, they want to know how to get into that new idea and make it work for them. Keywords with thought, vision, process, got it, modified programs, apps, there's an app for that. Those things are emerging almost daily. We can't keep up with them. I've got one teenager in the office, and that's her job, is to find new apps and decide what to do with them and adopt them and test them. And when I talk to her every day, she cannot keep up. So it's a lot of fun. Complementary services, expansion, value-based networks, direct contracting, population health, this whole idea. You'll have some excellent topical presentations today about moving beyond the on-site program to how the on-site program can channel into other programs that are going to work well for you and be a direct benefit. I'm going to let John talk about some of the key ideas that I presented just at an overview, and he'll drill down on the concept of what an on-site clinic has become and how these programs work. So, John?
Thank you, Mike.
For this, there you go.
You're
going to do that. All right, excuse me.
What an exciting time to have on-site clinics and the changes that are taking place here. Let's just quickly kind of reset here a little bit here, and Mike's teed this up very well. In terms of the on-site concept, implies the development of a program, not a place. Very often for those people who have on-site clinics, you think, well, the accomplishment is the on-site clinic. We're done. when the journey of what really happens with on-site clinic begins with the clinic. It doesn't end with the clinic. And so it's really a program. And as we struggle with an evolving program that's constantly changing based on the dynamics of the market, our own health benefits, the cultures of our company, the clinics change as well for that. The on-site clinic development puts everything on the table. And so the question is, for those of us who have clinics, and you think about the benefits and all the things that surround the clinic, wellness programming and disease management and population health, how do all those fit into your on-site clinic? So that everything is on the table. When you put that clinic in place, you question everything that surrounds it. How does this clinic support all the things that you're doing at your plant or your office? How does the benefits support that, and how does the clinic support those benefits? The design and the development of on-site program impacts every aspect of benefit design strategy. So when we sit down, and in full disclosure, QuadMed is our vendor, partner for this because we own them. So that's part of the reason for that, and certainly one that we value, their relationship. But what we do is we sit down and talk about strategy with them. We want their input as we think about our benefit strategy for next year, and we want to tell them what we're thinking so that the clinic can support those activities as well. For many of us, and depending on the size of your plant, the on-site clinic in and of itself is probably not cost effective. Depends on the size. If you got 750, 1,000 employees, it's probably making sense. And by making sense, I mean you take the visits times the value of the visits that you could buy in the marketplace, and you determine, is this an ROI for us? But for many, we have 9 clinics. Some go as, in Wisconsin, we have 3 of them that serve a little over 6,000 employees. But we also have markets that we have 600 employees at a clinic. But yet we feel the value of that, even though it may not turn an ROI that we think. So there's other ways to evaluate the clinic. And it's got to be part of a larger strategy and meet any number of objectives. And we talked about disease management being one of them, or wellness. When you think about the clinic and a wellness program that you're having, the question is going to be, how does my clinic support wellness? And how does wellness support the clinic? Or disease management, or population. Any of those strategies that we're doing can't be outside the box with the clinic, because the clinic kind of raises the bar a little bit in terms of integration. What are we going to do for that? So it does not have to be, the clinic doesn't have to be on-site. That's what we keep thinking about. Once the program is defined, it can be delivered from many locations. So for most of us, as again, most of our clinics are on-site. But what about near-site? What about virtual? What about texting and digital? So we have to rethink the model a little bit instead of just always thinking it's bricks and mortar. And so it can be delivered in many locations, even if you don't have a provider at a certain location. As we talked about shared and virtual, we're going to be experimenting a little bit with virtual clinics for us. We have capacity in some of our sites for our providers who aren't as busy as we'd like them to be. They're building a practice, whatever. So what we're experimenting with now is taking that capacity of a provider and putting it into a smaller plant that has an exam room, has a nurse, but now has a virtual doctor. So that the nurse takes the vitals, does all that kind of work, and prepares the patient, puts them in the room, seats them, and introduces the doctor to the patient, may step out for a while, come back in, and help the doctor if there's other things that need to be accomplished or explain the diagnosis or the treatment or whatever it is we're going to do. So virtual is kind of emerging for us as kind of a new way to think about healthcare. Many parts of the traditional on-site program can be useful to any beneficiary, whether they use the clinic or not. So for us, about 40% of our population has access to a clinic. 60% does not. How do we impact that part of the population that doesn't have access to us? And so we're looking at a variety of ways that the clinic can touch patients who don't walk in. Maybe it's an email, a text, a message, a phone call. Our corporate medical director for 20,000 employees sends a quarterly letter to each employee's house talking about a certain issue. Last quarter it was opioid abuse, what you should be doing to protect your family. The next one's going to be on antibiotics. So that is now either an email, a letter, or now we're doing podcasts. So we want this medical director to be seen as a trusted and valued resource for every family, whether they use the clinic or not. Call this doctor, Dr. Murkow, if you need questions or if you have questions. So the question for us is going to be, how do we extend the touch of the clinic beyond the four walls, which is a challenge. Lastly, as Mike talked about earlier, vendor is part of a cost of a clinic if we're using vendors. But really what we want to look at is a partnership between QuadMed in this case or your vendor or partner. That's a different equation than we've had historically. These partners can be health systems, they can be the vendors, traditional vendors that we're using, whatever. But we're looking at this as a partnership, and which means we want to raise the bar and expectations in terms of the strategy, where we're going as a clinic, because where we were 5 years ago, 3 years ago, is not where we want to be 2 years from now. So the clinic, for us anyway, and I'm sure for you, is always evolving. We're changing what we think about the clinic, how we want to deliver the services there, or beyond there. That's what we're really working about. So when you think about a vendor, are you thinking about a partner, or are you thinking of just somebody who's going to deliver care at the lowest cost I can find? Which is certainly going to be a consideration. But is it the only consideration? And that partnership is a question of, can we strategize together? Can you bring something to the table that helps me as an employer understand what I should be thinking about? Because you're managing a number of clinics in a variety of sites around the country. You have insights that I don't have. My view is going to be very myopic. And so we're looking for partners as part of that. Michael?
Yeah, I guess a question that we would ask is for you to consider some other terms. Use the term self-directed. You're self-funded. Most of the clinic employers are self-funded employers. Think of self-directed. Use the term staff model HMO, because that's actually what you are. We'll talk about that in a moment. Focus on the employer-centered or employee-centered and the employer-managed model. If you think of these terms when you're developing and designing these programs, it takes on a different focus, absolutely different focus. And the vision has to be defined by a totally different cultural approach to benefits, because when you buy benefits, that's different than when you develop benefits and work with benefits. You ask yourself a question about the staff model HMO. Full risk on a defined population, total risk. Risk is not, I'll reduce your fee if I don't get the clinic running on time. That's money-back guarantee. Risk is when you are a fully insured, or you self-insure your population. Consistent staff of dedicated providers. A provider is, of course, physician, nurse practitioner, whatever. Manages care, contracting, claims, and prevention or intervention. So they're managing claims. They're managing all aspects of the healthcare transaction. They use insurance, stop loss, or reinsurance or whatever to reduce their risk, and they make their own rules. Well, guess what? That's what an on-site clinic, employer-managed healthcare program does. It's a staff model HMO. We don't like that term HMO because it's been maligned a little bit, but it's really a very focused staff model HMO. And if everybody thinks about it in this way, you're going to use some metrics and some ideas that are different. On-site programs can fail. If you don't project something, no wonder you don't manage it. So we have to manage against projections, but if our projections are sales projections rather than internal to the population, then you'll wonder about it later when you're trying to recast your capital budget to fulfill another contract. Vendors themselves, partners, they'll kill the program. So in other words, you've got to be working with a partner, because some of the surprise situations we've seen have not been employers who are reconsidering the on-site program. It's the purveyor of services that's reconsidering their relationship with the employer. So it's the idea of, we really can't work this business model anymore. Let's give these employers notice that we'll no longer be a partner with them, we'll no longer be a vendor. So they'll kill the program when it no longer meets their business case. Programs need justification among a variety of audiences. I guess I don't have to tell you that. It's legal, the benefits people, the CEO, the board, and the patient and the beneficiaries. And the key metric that you've got to keep going back to, even though we'll look at lots of metrics today, it's employee beneficiary engagement. So, summarizing, employers and employees are in a position to impact healthcare delivery and performance. There's very great value in arbitrage and leverage. You don't realize it until you try to use it. The on-site model can be successful in many different forms, as John says, and the model also can fail for a variety of different reasons, not just because the employer fails to achieve what they want to achieve. John?
Thanks, Mike. For those of us who have on-site clinics, the question is always, how are we measuring this again? The obvious one is, what's the counts? What's the visit counts, right? I mean, that's the obvious and the one that we hear most often, and it's an important one, by the way. And what we do with that is kind of measure the counts that we're going to see in that clinic and then kind of weigh that against what we pay for it in the market and wonder, did this clinic pay for itself? And the question is, there's a lot of new things and new ways that we can measure the success of the clinic. For example, one of the things we look at is not how many patients we have, but how many new patients we have. How many new patients came into the clinic in the last month or the last quarter? How many of them are unique? How many of them are family versus employee? Are we making inroads on the family side of it? What is the compliance? So right now with QuadMed, they're adding something called Care Manager in the EMR. And so what that does is look at, a number of things, but what it does is also look at preventative screenings for cancer. And so that if they can't find something in the chart that says you had a mammogram or a colonoscopy or whenever it was appropriate, a flag pops up the next time you visit the clinic. And we can measure that. What's the compliance? How many people are doing their preventative exams? So more and more we're moving away. We need the counts, but more and more we're viewing it, measuring the clinic in different ways and how well they're performing in terms of our population. We want to link those measurements to action. So if we see deficiencies or if we see some good work, how do we improve it? If families are using the clinic, how do we get more family members to use the clinic? What's the strategy of that? Or if we find people not using the clinic recently, why is that? What can we do to improve it? So measurement should generate some response in terms of action plans. We're not going to argue about quality. I mean, the question is, how do you measure it? And in clinics, yes, satisfaction is going to be a key part of it. Our experience is if the patient comes, their families come and use the clinic, that's a great sign of quality because they're there. We also have clinics where if the providers aren't good or the staff isn't good, people don't come to the clinics, which is another sign for us that we have to make changes. So, for us, it's access, reporting, guidelines, compliance, communication, satisfaction are the measures that we're using now. And so the question of access is, how can we have the clinic touch people beyond walking through the front door? And whether that's a phone call, a text, going into the cafeteria and doing blood pressure checks during lunch, what we call brown bag lunches. Occasionally, we have a room during lunchtime where one of the providers or a nurse will talk about diabetes, talk about asthma management. So how many people are touched that way that may not use the clinic? Or do something in the evening for the families that we can do that. So we want to make the clinic more proactive instead of the clinic providers and staff waiting for somebody to walk through the front door. Looking at it much more proactively. And this should, foster radical change for us. And I think it probably has for most of us who's opened a clinic. As I say, it's not just opening the clinic and saying we're done. It's opening the clinic and rethinking how we're going to deliver services to our population, especially at that site. Which is a radical concept because what we've traditionally done is bought those services in the market and oftentimes not happy with them. We're paying for most of it. When we can bring those resources on site, we can tailor them to our population health. We can rethink our benefit design to encourage people to use that clinic, whether it's offered for free or $10, there's no deductible. Those are really powerful incentives to drive people to the clinic. And we have to rethink those constantly to say, are we getting the results that we wanted when we did this? So, how do we leverage access? Well, one of them is we talked about is virtual access. We had a physician, an internist at one of our clinics in West Dallas in Wisconsin who had to move to Kansas for family reasons. She had a very strong practice. Okay, she didn't go into a new job, but what we decided to do is say, do you want to practice medicine out of your home in Kansas, back in Wisconsin? She has the nurse. She has her practice. And so for almost a year now, she is about 65% busy caring for her patients in Wisconsin. About every 5 or 6 weeks, she'll come back and spend a week with us, but her patients want to stay with her. Now, that's not good for everybody. Some people want the touch. But for practice that are established, we're finding that virtual visit to be extraordinarily powerful for them. Retail access. We all have urgent care centers around us, other doctors. How do we integrate those into our thinking of healthcare? Instead of just limiting it to the clinic, how can we work with some of those nearby clinics that can offer services on the off hours? Call systems, reaching out to people, having people reach out to us. Hospital emergency department contact support. In most markets, we'll reach out to the local hospital, especially in some cases, they're the only hospital in town. What can we do to make sure we're getting the notes back from an ER visit, especially if you know there are patients? Linkage to telemed services. We use Teledoc at no cost to our employees, 24/7 access to a physician. We find that extraordinarily popular among certain parts of our population. And what we're learning is segments of our population react differently to different things. Some people love telemedicine, to talk to the doctor on phone. Some people hate it. They want the touch. Some people enjoy the virtual visit. Other people don't. So the question for us is, how do we segment our population to make sure they have access to the services that we need to provide? Pre-hospital services. You know, if you're going to have a surgery or a procedure, you need a physical, you need an x-ray perhaps, or you certainly need labs. We'll be the clinic of sight. Don't have it done at the doctor's office, come to us. We'll do this at no cost for you. Program follow-up visits after the ER visit, after your surgery, come on back to us. We'll schedule that patient for you now, or that home for you now, visit now. Home monitoring, what else? So, I mean, the question is, as you rethink the clinic and the services you can provide, don't think of just they have to be a patient. Because we can do a variety of new services there that provide access to those patients who may not use us on a regular basis. Michael?
The question that comes up in healthcare when you're doing planning for populations is, what if we had the best doctors connected to the most efficient hospitals? We know we don't. We have doctors connected to hospitals where there's an economic relationship. What about if patient care was in the most appropriate setting? What if that happened? Not in the emergency department, but perhaps an urgent care center. Or specialists were selected for access and value. Waiting 3 weeks or 4 months for an orthopedic exam, time off from work, but it doesn't necessarily mean you're getting quality orthopedics. It means that you're waiting for orthopedics. You're waiting for that next specialty event. And what if the beneficiaries knew which doctor, hospital, specialist setting was best for each issue or problem in real time? If they could actually connect with someone who would help them. This is where the employer needs to be, and John referenced the trusted colleague, the trusted compatriot. If these things happened, these 4 questions were answered positively, you'd find that healthcare costs would go down, satisfaction up, quality go up, value go up. What do we got coming? Reform's going to have little or no impact, absolutely no impact. Things slowed down a while when the Obamacare stuff happened, because we were confused, but we now see that on-site clinic and the progression of employers being involved is going to continue. Consolidation among programs will continue both at the employer level and at the responder, provider, partner level. Competition is going to be more regional. We see tremendous program growth among regional service providers, really challenging the national groups, and the national groups challenging regional providers. Very innovative and intriguing and captivating and exciting pricing structures are going to emerge. Capital is going to be a factor, so the idea of the employer providing capital, we're already seeing clinics being built by healthcare systems and providing much the same thing with a different source of capital. Contracting will incorporate real risk, not just money-back guarantee type of risk. And some large employers, some have already done it. Many will simply start to take it in-house. So that's what's coming. That's what we're preparing for. That's what we're looking at. Porter, who's a thought leader in healthcare, he charges a tremendous amount. If he were here today, he would tell you that the absence of comprehensive, rigorous outcome and cost measurement arguably the biggest weakness in the healthcare system. The fact that value is not measured means that the most powerful tool that you can use for care improvement is lacking, is being ignored. I think that's a segue into what Larry's going to talk about later on, an extensive amount of work that's been done by NAWHC, the board, select committee within the board, and other consultants to determine and define what should be and could be measured. And so that's a whole other topic later on today, which I think is one of the biggest changes over the last 20 years, the fact that we now have very reliable metrics. So I guess I'll pause for a moment and see if there are any questions or any other comments, and turn it back over to Larry, hopefully almost on time, Larry.
Let's thank John and Michael, please. So, at your tables, you have note cards. If you want to put those notes, write those down and hold them up. Our staff will pick them up and bring them up to me. Otherwise, if you have questions, we've got a microphone. Any questions for John and Michael at this point? Let me start out with one for you. How do you pick a vendor? With all the different options, and let me add to that.
We suggest hiring a very expensive consulting group. Just my thought, I don't know, there might be other ideas. But.
Well, let me change that question a little bit, Michael. A lot of hospitals and medical groups are getting into this field now, finding as the movement from volume to value that this is a great business opportunity, as well as expanding to their patients who are at the worksite. You work with both employers and vendors in hospital systems. How do you pick between that different kinds of models?
First of all, you don't need a consulting group. It's interesting that within the last, let's say, 4 years, 3 or 4 years, you can pick up RFPs. We'll send you an RFP for our request for proposal, request for information form for free. And really what you need to do is you need to look at the criteria you would use. We always would suggest that local healthcare systems and large physician groups, maybe brokers, be brought into the mix and ask and make them aware of what you're doing, because this is always perceived as competition. Actually, it could be collaboration as well. So there are probably 10 nationally recognized vendors, people who will go throughout the nation and provide a proposal, respond to an RFP. But then usually you'll find in large regions 3 or 4 regional vendors. And the regional vendors are very hungry right now. They're trying to get into the programs and they're trying to get into your firms. I think a firm that doesn't have an on-site clinic probably will be called upon by vendors. Don't take the last salesman that came in through the door. Do your own search just like you would with any procurement process.
Okay, thank you. For those on the internet, please put your questions in the chat box, and Mindy will get those to me. Again, questions from the audience? Yeah, Craig?
Yeah, good morning, Craig Thorne. Question for John, please. What technology do you use for your virtual patient visits?
That's a great question, because technology is evolving and changing so quickly. So right now, it's pretty much of a secure Skype model right now for virtual, but we do have the where we're going to experiment is to have the regular exam room there as well, supported by the nurse. So there's Skype, there's other things that you can look in the ear, look in the nose, things like that. So the technology is evolving so quickly. So that's one part of it. The other part of the virtual visit is we're doing something with diabetic management. And so we're rolling out a pilot program and we manage diabetes within our own clinics and within Quad Med. Is what we're doing is linking the meter, the glucose meter, with an app. And that results are sent automatically to the nurse diabetes coordinators. So they can see each day their patients and what their results are going to be. And now we're trying to figure out how to get that over to the EMR so the doctor can see it, quite frankly. So this technology is changing so rapidly, and we're trying to figure out how to take advantage of it securely, and who's comfortable using this technology as a patient and as a provider, because now it doesn't fit for all these people, but that's how we're working with it now.
Great. Okay, any questions?
John.
Wait, hold on a second. Emily, you'll get quiet. For people on the internet, they can't hear unless you speak into a microphone.
John, you mentioned this, I think you said the care managers now inside your EMR. It sounds like you're flashing gaps in care. Could you basically talk a little bit more about that? front page of the EMR so your doctors see it going in and what you're pulling from?
Now, the challenge for most of us, and certainly from the provider side, is the EMR is certainly a great leap from where we were with paper charts. But it also, what we miss is the opportunity of the doctor having to literally go through the chart to find out, did you have your exams? Did you have your foot exam if you're diabetic? Did you have your preventative exams? Things like that. And so what we're doing now is there's something called Care Manager that's bolted on to the electronic medical record that we're using. And basically it does a profile, and it looks at certain things in the chart and says, these things were not done. So it's a gap analysis. And there's a number of things. So we're only looking at 4 right now. And then evaluating, giving doctors feedback so they can see how they're doing compared to their colleagues and where we're going with that. So, I mean, this is new stuff. Some doctors embrace it. Some doctors are a little threatened by it. But we think this is the next direction that we're going to have to go here. It's something called Care Manager, which is it extracts certain information and shows if you're doing well with that patient or if you're not doing particularly well with that patient and what the gaps are.
Is it all tied back into the charting, or do you go into other data sets for that information?
Right now it's just in the charting, but again, for those of you who have a data warehouse, we've dumped that into this. So now our challenge now is we have a wealth of information. How do we provide more data back to the clinics in saying who's now diabetic that you don't even know about? Who was at the ER? Because we're looking at any visits over more than 1 visit a quarter. And giving that back to say, that's one of your patients, why are those patients showing up at the ER so often? Well, the doctor would never see that. And so the question is, how do we integrate the data and the metrics that we're seeing and giving that back to the clinic so they're better armed to care for their patients that they may not even know about? That's going to be the challenge of the future, because we have a lot of data. We know it as an employer. How do we get it to the provider so it's valuable for them?
All right, let's thank John and Michael for a great presentation. And I want to give my personal thanks to Michael for, again, helping develop NAWHC and creating it in the organization it is, and for John to be the first chairman of the board, who's really made a difference in everything that we do. At this time, I'm going to switch projectors here. It's a pleasure for me to welcome our next speaker, Ray Fabius, co-founder of Health Next and former director of GE and Take Care Clinics. Ray is a physician executive who has served in academics, private practice, and medical care, managed care, healthcare industry, etc., within the vendor space in a variety of organizations, with ITEC, CHD Meridian, Walgreens, and most recently the knowledge management space with Truven, formerly Thomson Reuters. Ray has written a number of articles on the industry regarding measurement and the approach of healthcare. He has one of the leading approaches to how to take care and begin a clinic, and I want to welcome him and thank him very much for his contributions to our organization. So please welcome Dr. Ray Fabius.
It's a great pleasure to be here, and Larry, thank you so much for inviting me. You have actually an awesome schedule of speakers today. I'm honored to be sandwiched between Mike and John and Vic. I saw him just a minute ago, and later in the day you get to hear from another giant in the space, Wayne Burton, and also my very good friend Craig Thorne. So it's just a delight to be able to share the stage with all of them and to be here with you today. One of my great passions for a very long period of time has been this idea of trying to change the dynamics in healthcare from patients having to go see a doctor when it's absolutely convenient for the doctor. I just called to make an appointment with my eye doctor, and I'll be able to see him on a Tuesday 3 months from now. That has to stop. And one of the ways that we're actually forging a new path to change the dynamics is by bringing doctors and other clinicians to where the people spend a good portion of their waking hours, the workplace. I'm proud to share this picture. Mike and I have sort of flashbacks to the creation of this, but now many years ago, my company, which was sort of a grandfather of the company that's now known as Premise, built one of the Taj Mahal health centers at Toyota facility. And just to accent the statements that John and Mike made earlier, where in his final thoughts he talked about the employer taking over much more of the delivery system, it's worth noting that Toyota, at its major factory facility in Japan, doesn't just have a health center at the workplace, it has a hospital. So there's even that as a possible way of advancing the utilization of workplace health and health centers. I have had a wonderful journey. I share some of this with you just so you can get a sense of where I'm coming from. But I did spend 10 years as a frontline primary care doctor and then another 10 years in the insurance industry with Cigna, U.S. Healthcare, and Aetna. I was the global medical leader of General Electric. I'll share with you before we're finished my network of on-site health centers. At the time, it was the largest network of on-site health centers, certainly at the employer level, and it actually even was at the commercial level at the time in the 2002 to 2005 range. I was asked to become the president of a sleepy, failing disease management company that had bought an old but standard occupational health center company. And together with the work that we had done in disease management and the work that had been done for many years around occupational health, we started to reinvigorate the on-site health space. This is in the 2005 to 2008 period. Subsequent to that time, I've had a chance to do some other things, including be the population health specialist for Walgreens, and to be very involved in retail clinics, and then to be the chief medical officer for Truven Health Analytics, which is now part of IBM Watson Health. But one of my true passions has remained this idea of bringing more and more health delivery to the workplace. And most recently, I started my own company, Health Next, which has been studying a much more comprehensive view of where employers should go in regards to health, and I'll even say well-being, and we'll close with some of that discussion. I've had the privilege to write 4 books. I want to plug one. This is now the leading textbook in the space of population health. The subtitle's called Creating Cultures of Wellness, which is really we're going to get to. I can shamelessly plug this book because all of my royalties go to the new College of Population Health at Thomas Jefferson University in Philadelphia, where I teach. When I was asked to take the presidency of a company called CHD Meridian Eye Tracks, which is now which was a predecessor of what we call now Premise as a company, we did an analysis of the marketplace at that time. This is 2005. And in 2005, you could see that there were over 500 locations where there were 5,000 employees working in one site. And there were 5,000 locations where there were at least 1,000 workers. And there were 10,000 at the time locations where there were at least 500 workers. So as we talk today about advancing the utilization of workplace health centers, it's good to eye the prize. Now, this was done by a marketing firm for us in 2005. My guess the numbers are perhaps changed to some extent, but probably not that much. So you can get a sense of what the marketplace is in terms of penetrating single sites. But as John talked about earlier, coalition models exist, and other, let's say, every industrial park could share a workplace health center. So there's an opportunity to penetrate the marketplace even beyond, I'll say, these 15,000, 16,000 locations. And when you start to look at advancing the use of workplace health centers on a grand global scheme, which is, how do we, as an industry, penetrate the marketplace, one of the key features, which will be a theme of the second half of this session, is proof of concept. I mean, nobody really wants to put down the kind of money that it takes to really build a workplace health center without some confidence that they're going to get a significant return on that investment. And I implore all of you here to contribute to the medical literature as you start to identify increasing evidence of the merits of using workplace health centers. And it can start with something as simple as reduction of injury, cost savings. It starts to get really interesting when you can start to show evidence that the workforce that's being treated by this health center is actually getting healthier over time. And there are now methodologies to evaluate the illness burden of a population. And you can actually do that analysis, sophisticated analysis, and show that the workplace health center is actually making the people who they're taking care of healthier, or what I like to say, younger over time. And then lastly, the final hurdle, which is the interface between medicine and industry, is demonstrating that as a consequence of making populations healthier, they are performing better. And as a consequence, the organization performs better. And I look forward to sharing with you research that I've been dedicated to completing over the last 4 years that can show that on a remarkably global basis. Another important opportunity for this industry is to stop just thinking domestically. This is an opportunity globally. And for those of us who were global medical leaders, as I was for General Electric, I wish I had a vendor partner that could have helped me in the 29 countries that I had workplace health centers in. So let's stop thinking that this is just a domestic idea. We think that it's a domestic idea perhaps because we believe that we have this, I'll say, different healthcare payment system. And since there is a socialized healthcare system in most other countries, it may not be attractive for employers to have doctors and clinics at the workplace. But you know what? Outside of the United States, whenever I speak, it's so much easier to talk about the productivity gains that are accomplished by making workforces healthier. They appreciate the merits of that much more than we do, and for that reason, they are eager to put workplace health centers in for their employees as well. And then lastly, and I won't belabor this because it was a major theme of Mike and John's talk, is the idea of having a Chinese menu of options that you can actually have on-site or near-site or develop direct relationships with the existing base of providers that are in the community, or create high-performance networks. The great news is that this industry is attracting increasing interest and attention. And so whatever you folks are doing to move this movement forward, you should celebrate. And yet there's still tremendous opportunity. This is a slide that I used in 2005 when I was promoting workplace health centers. I said the value proposition was really based on 4 key concepts. One was being the employer of choice. When General Electric decided to put workplace health centers into Shanghai and Beijing, it was because we thought that we would have a competitive advantage in attracting the best and the brightest talent against other multinational companies that were in the same marketplaces. Being the employer of choice has a tremendous amount of value. It reduces turnover, it increases loyalty and engagement. Worker safety is a real simple starting point for any workplace health center. And moving on, as was mentioned this morning, to doing everything you can to deliver higher quality care and reducing costs. So why workplace health? I mean, this is just a quick summary of some of the literature, and some of the literature that I've written in particular. First of all, there is one sad number that I want you to keep in mind, and that is that in research that we've done at my startup, Health Next, 40% of the covered lives that an employer provides benefits for has 40% has no trusted clinician. They have no primary care doctor. They are what we would like to call, and you should write this down and use this language always, they are medically homeless. Now, as soon as you put a primary care doctor or even a nurse practitioner at the workplace, you can eliminate this 40% medical homelessness. Now, other organizations like the Commonwealth Fund have done their own independent work and have suggested that it may only, and I would use only with capital letters, only be 25% of the covered lives. But if you don't have your people establishing any trusted relationship with any provider when they get sick, I'll just say all heck breaks loose. There is no one managing the care. There's no one directing the care. Your employee or covered life hits the emergency room, and they get what I like to call, and you should write this down, random access to care. They get whatever happens to happen that day in that emergency room. Random access to care. So what you have the opportunity to do by putting a workplace health center in is eliminate the medically homeless and eliminate random access to care. There's huge, and the studies are very clear, there's huge savings that can take place there. How many of you here are from a human resource background and training? All right, so as I read your literature, you're told that the way you can attract a remarkable workforce is by making sure you get people who have the skill and the will to get the work done, right? That's the reason why when I apply for a job, you guys ask me first for my CV because you want to figure out whether I have the skill, and then you interview me to see if I have the will. There's another part to this that we have to consider very strongly if we want to have a high-performance workforce. They have to have the skill, the will, and not be ill. And not be ill. The lost productivity impact of illness is at least 2/3. If you focus on healthcare costs, you're focusing on the trees and not the forest. The real reason why you want to put workplace health centers in is to maximize the performance of your workforce. For God's sake, it starts with the idea that if one of your employees is sick and they want to go to see a doctor, it's going to take them a whole day from work to see the doctor and to get a prescription filled. Which leads me to the remarkable value of on-site pharmacy as well. One of the great challenges that we have in this industry is actually trying to measure what didn't happen as a consequence of putting in our workplace health center. Think about that for a minute. How do you measure what didn't happen? Because we took better care of diabetics, the following things didn't happen. Here's an illustration of some research that I did way back in 2006 and 7 and 8. where we actually, for an employer, identified 336 diabetics who were out of control. In fact, their hemoglobin A1C, while it should be close to 7, was over 9 on average. But over a 3-year period of working diligently with them on site, we were able to get them under much better control. Now, based on predictive modeling, we knew that over a 10-year period, these 336 diabetics, if they remained in poor control, would experience the following things: 10 amputations. 5 of them would go blind. 7 of them would go on to renal dialysis, arguably the most expensive patient on earth. And 84 would have a heart attack or stroke. Now, because we put them under much better control over the next 10 years, instead of 10 people losing a leg, we would predict, based on our analysis, that only 7 would. Instead of 5 people going blind, only 3 would. Instead of 7 going on dialysis, only 1 would. And instead of 84 having a heart attack, only 40 or so would have a heart attack or stroke. Then, that might be enough to convince the clinical people in this room, but the business people may want that converted into dollars. So as a consequence of saving 3 amputations, 2 episodes of blindness, 6 people from going on dialysis, and 44 heart attacks and strokes, we estimate that this program, which cost pennies to the dollar, would save about $6 million over 10 years. It's just 336 diabetics. This is just scratching the surface of what's possible that we can do to prevent things. And by the way, I'm just talking about medical costs here. We were doing this for a heavy manufacturer who retains their employees. And just about all of these workers were working on manufacturing lines. And by the way, from a productivity standpoint, it would be very hard for these people to do their job if they only had 1 leg, or if they were blind, or if they had to go to dialysis 3 times a week. So the productivity gains for this are enormous. Way beyond the $6 million, and we would estimate that it's either 2 to 3 times greater than that. So I implore all of you in this room to start to measure the things that you're actually making not happen, so that we can really start to generate a greater understanding of the merits of working so hard to keep workforces healthy and well. This is a map of the 230 workplace health centers with the 650 doctors and nurses that I was responsible for managing at General Electric. Most of my clinics were not in the United States. If you want to start to work toward higher utilization of workplace health centers, you have to think outside of our borders. And as was mentioned earlier today, you need to be thinking all the time about how does this clinic that you're utilizing fit in with all the other clinicians in the community. And we would all recommend that it should not just be a standalone clinic, but that it should integrate with the other services in the community. This is Mike's first book. And I would say arguably the best book on the topic of on-site healthcare. And in it, he features the work that we did at Toyota together, where we built a high-performance network on the back of the workplace health center in San Antonio. And by doing that, according to Toyota, we saved them $1 million a quarter just in specialty costs and hospitalization. It is remarkable what you can accomplish when you narrow your vendors. You know, when any employer is trying to build something with nuts and bolts, they don't use 47 different suppliers. They narrow their suppliers to just a couple, and then they manage those suppliers with a great focus on quality. You can do the same thing if you put primary care inside your health center and then put a referral manager who is helping that primary care doctor refer to the best in the community that you've already established a separate contract with. It's possible. You can connect a workplace health center to a high-performance network. You can shift the care to the high-quality, high-performance providers that you have under contract within 6 months, as our study showed. Let's just digress now for a few minutes, because I think Larry also wanted me to comment on how do you get people to go to the clinics, because this is another part of advancing utilization of workplace health centers. So part one was how do we get more health centers in across the globe, and part two is how do you get people to use the health centers once you have them in. And there's a very sophisticated marketing and communications approach that we can take to this. And it was a very sophisticated approach that we took to it even in 2005 to 2008 when I was the president of iTrack Meridian. And these are just some of the component parts. I'll speak to a few of them. So the benefit design is really crucial. We'll talk about that. You can use incentives. Embedding other services in the health center, including a health advocate, makes tremendous sense so that you help people not only get good care, but you help people access the best that the healthcare delivery system in the community and beyond has to offer. Getting the right providers into the health centers is crucial. And what we normally did at iTrack Meridian was we would actually provide the employer with 3 choices, and they would pick which doctor or doctors made the most sense relative to their workforce and their community. We made a tremendous effort to try to draw from the local clinical talent, because local physicians to those clinics would be already well known to the community, and they would already maybe even be well known to the workforce. And they would also understand the milieu of the region, the culture of the region, and the culture of the healthcare community. So I would encourage you to, regardless of what vendor you might use or how you set things up, to spend a lot of time getting this right. I'm going to skip this because we talked about it. I want to focus a little bit more now on benefit design. As you can hear from my introduction, I've had an opportunity to work in all the constituencies of healthcare. I've been a provider, I've been a payer, I've been a purchaser, I've been a vendor, I've been a consultant, I've been an informaticist, and I believe that the purchaser, the employer, has the greatest opportunity to make a difference. And one of the reasons why you do is because of this benefit design. And for those of you that are self-insured, you have this tremendous opportunity to design a benefit structure that increasingly is scientifically based. You're familiar with this whole concept of evidence-based benefit design. So the way you set up your benefits goes a long way to the way people use the benefits. So if you decide to go with whatever shiny penny exists because everybody else is doing it, that you will continue to get double-digit medical inflation. So if you wanted to just buy HMO till nobody wants to do HMO, then buy PPO until nobody wants to buy PPO anymore, to then buy POS because that sounds like the nice new shiny flavor, and then say, all that other stuff doesn't make any sense. It's all high deductible health plans. And then, now maybe that's even starting to get out of favor in favor of a private exchange. All of these efforts have made the transition during a time when there's been a consistent double-digit medical inflation relative to, 2 or 3 time increase in medical costs relative to general inflation. So manipulating the benefit designs in some kind of traditional format is not going to adequately make a difference. What we need to do over time is we need to make it so that all people get things covered that we know are of high value, near 100%, and not get things covered that we believe don't have very much value, and those things maybe should either not be covered or be covered at a much lower percentage rate. If you move to a high deductible health plan so that people can have skin in the game, you will get a reduction of utilization of the things that are unnecessary, and you should take credit for that. And you will get a reduction of those things that are necessary, and you should take a loss for that, and you do every day as you pay out your costs. So this needs to be sophisticated, and it can be leveraged around a workplace health center in extraordinary ways. I mean, you can even reward people for going to the workplace health center. You can establish a point system, or even more importantly, you can actually reward your employees and the vendor at your health center for high performance. If together they're able to elevate the health status of your covered lives so that people are actually getting healthier, there should be some way to provide some shared savings from that cost back to the provider at the clinic and back to your employees. So ultimately, this idea of using the evidence-based benefit design and pay for performance can be an extraordinary way to use your dollars. It always makes sense to continuously work on barrier analysis, right? So you need to be asking people why they're not using the health center and correct for it. Almost every one of these questions that I have listed here has an answer. I mean, if the clinic isn't open when I need it to be open, you've got to look at your clinic office hours. If someone says they don't need any medical care, then they need medical education, health education, so that they can understand that everybody needs preventative services. And we move on to the idea in terms of advancing workplace health centers by integrating the workplace health center in remarkable ways. I mentioned pharmacies. When my company was sold to Walgreens, we actually had 28 pharmacy locations. We were moving $250 million of pharmaceuticals. Having the opportunity to integrate the prescribing and dispensing clinician at the workplace is magical. Articles that I wrote at the time showed there was roughly a 10% increase in medication adherence across every class of drug that I studied. There was much more appropriate use of medications, in this case a study that was published on a more appropriate use of antibiotics. More recently, I believe Wayne was the contributor to this paper as well. We wrote a paper talking about the importance of engaging in total worker health, as the Institute of Medicine called it, where health protection and health promotion are one thing. So we're actually advocating for the integration of all safety people at the workplace with all health people at the workplace. They should not be in separate silos. And ultimately leading to a series of standards that's consistent with a sustainability index. We believe that those who are in the investment community and who are focusing in on sustainability should include metrics around how the employer deals with their people. A green, sustainable company isn't just one that leaves a less of a carbon footprint. It's also one that takes good care of the carbon-based life forms who are making the products and services, for God's sakes. All right, so we move on, as was mentioned briefly by Mike and John, to integrating and delivering on the promise of population health. And when I talk about population health, when I was at General Electric, Jack Welch used to say, here's this book, read this and summarize it in one slide. We're all very busy. So for those of you that don't want to read my book, this is the one slide. But I mean, basically, what you want to do is keep healthy people healthy, which we normally forget about, but they are actually your most valuable players. You want to reduce the risk of people who have risks before they develop chronic disease. You want to provide rapid access to care when somebody has an acute illness so it doesn't fester and become chronic. You want to help people who have chronic illness not succumb to the potential complications. And you will want to provide centers of excellence and perhaps compassionate care for those that have catastrophic conditions. Sadly, when my company HealthNext goes into organizations to evaluate them across these 5 dimensions, every organization has significant gaps, whether it's the employer's efforts or a delivery system's efforts. There's still much opportunity just to deliver a comprehensive population health approach. Sadly, when you've done that, you have established a great platform. It's absolutely necessary, but it's not sufficient from the more recent research that we have identified at HealthNext. Now, some of you may be familiar with the research that I've done most recently, and that is looking at companies that have won awards for their cultures of health to see if they outperform in the stock market. And they do, remarkably so. And so in 2013, I wrote the first paper. This was based on companies who won the Corporate Health Achievement Award from the American College of Occupational and Environmental Medicine. I want to call your attention to this graph. This graph I never published, and I regret it. Because when I was at iTrack CHD Meridian, I was noticing that the employers who were buying workplace health centers from me were doing better in the stock market. And I pretended that they were a mutual fund, and they outperformed. My clients at CHD Meridian outperformed. By the way, I'd love to do this research and publish it if there's anybody, any one of you workplace health vendors that would like to share your research with me in that vein. More recently, I showed that companies that scored high in the HERO self-assessment, companies that won the Coop Award, and then I did some more elaborate studies with those that won the Corporate Health Achievement Award. I now have 13 different financial models, all showing a very close correlation between companies who have been recognized for their culture of health and their stock performance. These are the different standards that are used by the different organizations to establish their award. And as you can see, they emphasize different things. HERO emphasizes more wellness. The Coop Award emphasizes more data. And, of course, the Corporate Health Achievement Award from the American College of Occupational and Environmental Medicine emphasizes safety as well as health. We at HealthNext have been studying this now for a very long time, 8 years. And we now realize that you have to do all these things if you want to, dear employer, bend the healthcare cost curve. And we developed a methodology so that we can measure a corporate culture of health out of 1,000 points and benchmark companies who bend the healthcare cost curve, whose healthcare costs are either flat or going down, score in the 650 to 700 range. We've identified 218 elements in 10 categories that are required to build a corporate culture of health. This is not for the faint at heart. It's hard work, but it delivers what you actually are really looking for. This afternoon, you're going to talk about the return on investment from clinics. It's a great concept, and we have to publish it. But at the end of the day, believe me, employers are really interested in only one thing, controlling their healthcare costs. Jack Welch considered me an A player because our healthcare costs were going up 2% per year during my tenure, while most organizations had an 8% increase in healthcare costs annually. I'm telling you, that's not even the end goal anymore. There are now several companies whose healthcare costs are going down. I know it sounds incredulous, but it's happening. And the way they're doing it is by building corporate cultures of health, which includes a very significant role for on-site health activities. So when we go in and do our analysis, it's just like a health risk appraisal for a person, but we do it for an entire corporation. We identify gaps, and we help companies get to a score of 700. We help them better understand the progression of their disease, from the health risks that are prevalent to the things that they're spending their money on in terms of healthcare to their catastrophic conditions. And we say to employers, what do you want to do? You want to wait until these people are on dialysis, or do you want to try to create a culture of health upstream? And when you do, I know this sounds incredulous, but companies are now experiencing a melting away of their high-cost claimants. No, that's just not stuff that happens. It's preventable, but it takes time, and you have to build a culture of health to really make it so people don't have heart attacks, and they don't have strokes, and they don't have to go on dialysis. It's possible. And so, if you chronicle the way I've seen things over the last several years with my books, the world of medical management started with the HMO era and utilization management, and it's heading toward building cultures of well-being. It's very hard to do this in communities because there's so many moving parts. It's really not that hard to do in companies. And in the end, as was pointed out in the morning, it's really a matter of combining employee accountability with employer responsibility and the clinical capability in the community, all focused together on a culture of health. And benchmark culture of health companies are doing this around the globe. And it doesn't really require just large companies. Mid-sized companies are doing it too. In the book, in the article that Wayne and I wrote with others, talking about the integration of health protection and health promotion, we proposed here the next generation of on-site. So as was mentioned in the first session, when John said it's not a clinic, it's a program, I would say it's actually even bigger than a program. If you're doing this right, the next generation of on-site should be the hub of building corporate cultures of health. Thank you.
Well, unfortunately, I wish you could speak up a little more. Lack of intensity is bothering. Yeah. All right, questions. Please, come on. You all come here because you have something you want to learn or a question you want to deal with. This is the individual you want to talk to. Well, also those on the internet, again, please make sure you send questions in the chat box. Hold on a second. We'll get a microphone to you in a second.
So with HIPAA, your diabetes program, how did you find out who those 300 and some odd people were that you managed in the program? The problem we have is we have aggregate data that tells us about our employees, but we don't know who they are, and we offer programs, and they're not utilized.
Yeah, I mean, that's such a great question. So you circumvent all of this by putting primary care doctors at the workplace. The primary care doctors identify them. And then we can deliver a sophisticated disease management program in coordination with the trusted clinician. There are very good studies, including ones that I published, that show that if you circumvent the trusted doctor relationship and deliver a disease management program without including them, you only get a small percentage of participation, and even those that participate don't stay in the program. If you deliver the disease management program through the trusted clinician, particularly one at the workplace, you get 3 times greater engagement in the program and 5 times greater retention in the program a year out.
Thank you.
Pleasure. You need to get the mic.
Emily on the other side.
We'll get it to you.
Thank you. It's a great talk. My name is Ryan Bronze. I'm here representing the city of Rockford today, and I wanted to make really just kind of an editorial comment. You started off by talking about 40% of people don't have a medical home. We've got 1,150 employees, and when surveyed, we were shocked that 1/3 of them had a doctor that they used, okay? 1/3 of them had nothing, and the other third thought they had a home because they would occasionally go to the same clinician at an urgent care center nearby.
Yeah.
And that was really the statistic that led the city of Rockford to implement its on-site healthcare initiative, actually with Marathon Health, and it's been working very well. But we were shocked that when we revealed those numbers to the local hospital presidents, they didn't believe them.
Yeah, I mean, so you know what you're actually saying to the local hospital, and I consult and work with hospital systems. I say, guess what? There's 40% of in your case, 60% of the market share is still out there for you. Capture it, for God's sakes. Yeah, I mean, I probably should have stopped by just saying at the end of your comments, amen.
Larry Morrissey, former mayor of Rockford, Illinois. This is apparently the Rockford contingency table.
I'm ready to move there.
I spent, excuse me, Mr. Bronze over here was our broker when I was the mayor. He educated me a lot. Your 3 tiers, by the way, I could count my 3 terms in office. He'll tell you that he wanted to do on-site care in term 1, but it was literally my first term kind of lined up with level 1 when we were just trying to introduce into our public body copays, deductibles, cost, and price, trying to come up, get up to the 1980s. Tier 2, kind of your immediate, and then ultimately Tier 3, my third term, we finally brought on-site care. Now I'm actually on the other side in the private sector working with Marathon Health in government relations and sales. My question to you is, most of your talk was about the value proposition to the private sector, where logic and business decisions should be the norm. The challenge that I see nationally now is the same challenge I dealt with as mayor: local politics, driving decision-making with local hospital systems that I think are very sincere in their efforts, but just don't have sort of the legacy track record of doing this. I'm just curious, do you see any trends and any data that can help drive that public sector conversation?
Yeah, I actually, dedicated a sort of the remainder of my career to trying to publish as much as I can the proof of concept so that I can help contribute to the literature and the movement that will be so convincing that it will be able to defy political will. But in my own experience, like yours, approaching government purchasers who desperately need what you identified for your city, it's a slog. And the sales cycle that one engages in is easily 3 years under the hope that the administration that you're speaking to stays in power over that time. So you brought up a real opportunity. I actually do believe that if you can crack that code, you can run the table. And it may be through the great work that you've done in the city that you're from. That work that you've done, even in terms of a journey and speaking to the levels of benefits, has to be published. I mean, if it's not in a peer-reviewed journal, it has to be in a magazine. I mean, we have to get that message out, particularly to government entities, especially if you can demonstrate a bending of the healthcare cost curve as a consequence. Yeah. And even that survey that that you led needs to be published. It needs to be clear that we have to solve for 2 issues that I brought up. One is medically homelessness, and the second is random access to care. Medical homelessness, random access to care. In your case, 60% of your covered lives were experiencing both of those, and I'm sure you had rocketing as a consequence, rocketing healthcare cost acceleration.
Thanks, Ray. Great talk. Perry Taubman from the University of California at San Diego.
Oh, great.
And I had a question about the role of on-site health centers in the context of occupational health and safety, pain management, and opioid addiction.
Yeah.
Which is now, really hot topic.
Yeah. Again, one of the solutions that I would suggest strong consideration for is the integration of the prescribing clinician with the dispensing clinician. When you actually have a doctor working with a pharmacist, the review, that sophisticated teamwork review that can take place on every prescription can be quite remarkable, and it can actually meet formulary and clinical guidelines that you can't have control of when your workforce is actually getting their drugs dispensed at 47 different pharmacies. Also, and again, I mean, I got in trouble while I was the population health strategist at Walgreens. Also, one of the remarkable things that can happen at your pharmacy at the workplace is they could do something like not sell what? At your pharmacy that you control, what could they not sell? Cigarettes! Yeah. The other day, I'm waiting for my prescription. Actually, it was my wife's prescription for a medication, and I'm in line, and that shouldn't happen. But the pharmacist, of course, who's at one of these chains, was standing up one high, and he yells down from below, "Your Lipitor prescription will be available in a few minutes," to the person in front of me. Do you know what he did? He went around the corner and he bought a big bag of potato chips, I swear to God, and ate potato chips while he waited for his Lipitor prescription. And they were both available at this pharmacy. And so one of the things that I always prided myself in the pharmacies that we put at the workplace is that there was no junk in those pharmacies. We had over-the-counter medications for people, and we had prescription medications for people, and we didn't have anything else. Nothing in the front of the store that normally is there so that when people go to the back of the store and fill prescriptions, they buy stuff. You can protect your employees from that by having your own pharmacy. In terms of pain management and opioid addiction itself, there is no question that the occupational health physician can play a huge role in identifying people who have pain and exercising a multimodality approach that in many cases can avoid any use of opioids or limited use for a short period of opioids. And we do have, thankfully, a tremendous array of potential other therapies for pain other than just throwing some pills at it.
Thank you. Time for one more question from our people on the internet. Lori?
A question on the webinar from Abby Gray from The Wonderful Company. What models have you seen work well for measuring overall ROI of on-site clinics?
That's an excellent question, and I'm proud to have made a small contribution to the remarkable amount of work that the association has done in regards to this. And if she can wait until later on in our webcast today, she's going to hear not just my thoughts on ROI, but I'll say the best expertise that this country has to offer, summarizing their thoughts around how do you best measure the impact of a workplace health center. With that in mind, I feel compelled to at least say something. And what I would say to her is that as part of this paper, there'll be a reference to one of the key articles that has been published in this space by Bruce Sherman and myself, which I think is called a quantitative assessment of non-occupational health services at the workplace. So there is a published paper out there that she can look at that will give her some guidance, but a better tool will be the paper that's coming forward from the association.
Let's thank Dr. Ray Fabius, please.
I'm going to give you this book too.
Ray, thank you very much.
Yes, I'm giving him a copy of the book to raffle off here today.
Thank you very much. At this time, it gives me great pleasure to introduce Tom Sondergelt. Tom is currently the Vice President of Global Mobility and Benefits for Walgreens Boots Alliance. He's going to be talking about using data and telemedicine to manage health. Tom has been with Walgreens now for how many years? 7 years. Prior to that, he's worked for Hewitt Aon Corporation, Northwest Memorial Hospital's wellness programs and on-site centers. When he was with Aon, he began the first rollout of their corporate private health exchange and their use of 4 on-site clinics. In his current role at Walgreens Boots Alliance, he's responsible for overall HRIS technology, healthcare, and global mobility strategy for the over 357,000 global team members, and has implemented clinics throughout the country and the world for Walgreens. Also chairman of the Midwest Business Group on Health, and I like to call friend and colleague. Please welcome Tom Sondergeld.
So I think I'm sandwiched between two really great experts, and I think I probably could do a dance to get past what Ray just presented. Maybe that would be as exciting as what I'm going to give you today. I would like everybody to stand up for a second. I'm going to take a little survey. Plus, you need to stretch, so this is your wellness moment. But I'm going to ask you to stand up. How many of you, when you were young, dreamt of something that you are currently able to say you are living out that dream? You can sit down. How many of you had a dream and are trying to achieve it today, but have a few more things to do? You can sit down. And then how many of you haven't dreamt at all? Okay, I just want to tell you a little story before I start my talk. And it's something that happened today that I just think is amazing. And it's so amazing, and it's happened so many times now, it didn't even make the news. A long time ago, a young man dreamt of the ability to go to Mars. He wants to go to Mars. He's now an adult. And he is the only person who's been able to successfully launch a rocket into space, launch a satellite into space, and successfully land the booster on a dime on land. Did it today for the 9th time. Reusing that rocket, saving millions of dollars, NASA, with all of its power and might, has never been able to do this. What I'm saying this for is that Elon Musk had a dream. He's fulfilling that dream because he has basically thrown a middle finger at everybody that has said, I want to change the world. But you can't. He's going to change the world because he has taken the risk. And what I'm saying to you today is I'm going to share with you just a basic way a simple employer has tried to take a look at data and bring it in and justify clinics so that they make sense to a CFO who only thinks about a dollar sign. Because that's the reality of my employer world. Ray and others may be able to put papers out there and say anything about productivity, but I'll tell you, most CFOs will not buy into anything related to productivity in the United States. They want to know about the hard dollar savings. You put this thing in, it cost me $2 million, I want the return. When am I going to get the return? And you have to be able to demonstrate that somehow. So I'm going to share with you some ways in my career, putting in simple clinics, silently doing it across several different companies, and now at Walgreens, in a way that has gotten stand up with our CFOs that I've had to deal with. Some of them very tough, and some of them international. So I'm going to talk to you about that. But first, let's talk a little bit about Walgreens Boots Alliance, this big entity that we are now a part of. Walgreens Boots Alliance is a parent company of Walgreens in the United States. Walgreens Boots Alliance operates 13,000 pharmacies around the globe, soon to be about 16,000 with the acquisition of Rite Aid. We are about $100 billion in combined revenue, now about $150 billion actually. 400 clinics and 380 on-site clinics that we operate in partnership with providers in some locations and with premise in other locations. We have 65% of you all live within 3 miles of a Walgreens in the U.S., and in the U.K. it's equally even more because they're very dense with their Boots population. We service about 6.5 million U.S. customers a day. In fact, we did a little study, and did you know that pharmacists actually see patients more than doctors do on a repeated basis? So there's that connection that Ray talked about between the pharmacist and the doctor. When you can make that connection, it has sticking power because the pharmacist actually has a lot more visibility with the patient. 250,000 employees in the U.S., 350,000 worldwide, as Larry said, 210,000 healthcare members in our health plan in the United States, and we hire 75,000 people annually. So it's quite a big company, and we do a lot of stuff for our team members, and I'm going to talk about 2 of those today. our Healthy Living Center that exists in a couple of our locations that are pretty large in scope, and then our telemedicine approach that we've kind of put on top of the clinics to serve a vast population. We have 8,300 stores in the United States. Each of them have about 33 people in them, and they're all over the United States. So there's no way I can build clinics that impact all of those people. So how do we reach them, and what are the ways we've done to get out there in ways that matter? So I'm obliged to show you pictures. Any employer that does a presentation on their clinic, you have to show pictures. So this is our clinic. We're pretty proud of it. We built it in 2011. It launched in the Deerfield office, which is now the headquarters of Walgreens Boots Alliance. It has a great fitness center attached to it. It has a pharmacy. It's got all the beautiful makings of a well-run, well-established, beautiful-looking clinic, and it's kept this way by Premise that runs it for us. So we do take in a lot of vendor data. We worked really hard with what was Take Care and now is Premise Health, who runs the clinic. We worked really hard with them to establish some metrics that mattered to us and ways that we wanted to measure not only the throughput of the people that were coming into the clinic and their appreciation of the clinic and their satisfaction, but also the ROI and how we wanted to measure that ROI against what would happen in the community that we were avoiding. So a lot of it is built off of cost avoidance. And so I'm going to just show you some of the data. This is some of the data that you should expect to get from your clinical vendor, okay? And some of it's very basic. Some of it is just trend data. But one of the things we rely on quite a bit is this cost avoidance data. And we worked really hard to establish what this would look like. And what we did is we took some community-based data that is out there for our population, and we said, this is how much these services typically cost out in the community, and this is how much we're having to pay for them through the clinic. And then what is the difference? And if there was avoidance through an ER visit that could have been avoided or other methodology, that factors in as well. And so we got some very basic numbers about what the total avoidance was, what the total expense was, and what the net savings are on an annual basis. And this continues. We get quarterly reports from the vendor, from Premise, and we're very proud of the fact that we have returned quite a bit of savings. We've paid for this clinic, including all the bills, about a $5 million bill. We've paid for this clinic probably 3 times over now. We've established that. The WBA leadership, which is all from the UK, understands this and believes in it, and our CFO, who's from the UK, believes in it. And so we've got buy-in. We don't need to go much farther than that. This gets enough buy-in, and we show these numbers and we demonstrate these numbers. They're validated through audit that really help us get to the good place. This is just the start. This is the beginning of our foundation of how we build our data. It gets a little more granular. We're able to look at various things that we avoided and how we come up with that cost savings and the total expense and then get the net savings. And it's really nice to validate this. And the savings continue to grow as we continue to adapt and change the clinic environment for the members that are on our campus. So we get some very basic data about the throughput. We were able to react to this. It's important to look at this. We have had to look at this on a quarterly basis, sometimes even on a monthly basis, because as you can imagine, we were just Walgreens. Walgreens headquarters was in Deerfield. It was a massive organization in Deerfield. There were 7,000 people that were servicing the country out of that support center in Deerfield. When Walgreens Boots Alliance merged together and became an entity run out of Deerfield, but with all the leadership in the UK, that office started to shrink a little bit. And whenever you have a merger, people got a little leery and there was a lot of transition. And so we saw the clinic started to wane a little bit. And we used this data to demonstrate to the leadership that, hey, we need to do something. We need to re-engage the population. And so what we did is we opened the clinic to anybody who was visiting on campus, even if they were from the UK, from Boots. And they were able to go into the clinic. And one of the most interesting things is that if your leaders go, the flock will follow. And so they would see key leaders from the organization working out in the gym or going into the clinic for service. Or they would hear stories about successes that some of the leaders had who weren't even based in the U.S. And then the volume started to trickle back up again. So you can react to this data. It isn't something you should ignore. It is something that really should be paid attention to, even though it's just very basic data. We also pay attention to the satisfaction data. We look at satisfaction. We've had to, unfortunately, work with premise and make some decisions about a clinician not staying with the organization because of dissatisfaction, because of noise that we heard in the data that we were seeing, or because members were not going back to the clinic. And we would ask why, and they would say, well, the doctor kind of is not servicing me as well. And so we've worked with premise, and we've had to make some changes in the position in the clinic. But this data is very important for helping you manage your clinic. And one of the things I think Ray and others will allude to today is you cannot just set up a clinic and tell the vendor to run it. That's like putting a gas station on campus and expecting people to buy the gas. It's not going to happen unless you engage as the owner of the clinic. Plus, it's your fiduciary responsibility because this is part of your health plan in most cases. And because it is part of your health plan, you need to own it and have responsibility for it. So this data should be key to helping you manage with the vendor partner how you deal with the way the clinic operates and the way the clinic runs. It isn't just all about ROI. It truly is about throughput, satisfaction, happiness, the stories that are told, because word of mouth, I will tell you, Walgreens is the most interesting company. 240,000 people, 8,300 stores, but I could say something today to a manager in the support center, and by tomorrow, it will be in every location. Word of mouth has tremendous value. And so we even if somebody is visiting, they're not from the support center, so I'm in the support center, I get to go to the clinic. When we first set it up, that's how it was. But we've since branched it out, and now anybody who's visiting from anywhere can go to the clinic. They don't even have to be in the health plan. They can pay a fee and access the clinic. And so you can do this. Consult with your risk attorney for how they want to handle it. Just be very careful. So we look at a lot of different data. You can see we have some quarterly metrics. We reacted to this because we were starting to see the net savings were waning a little bit in one of our quarterly reports, and so we did some changes to the hours, and we changed how much we're paying premise because we were seeing that some of the throughput and some of the hours of the clinic weren't working as well. So you can respond to this. And then we also get reports from the people that are running the fitness center, the gym. It's important. You cannot just put a gym in and say, have a gym and enjoy the gym. It's an investment. It costs a significant amount of money. I would say more than half of the $5 million was spent on the gym because the equipment is very expensive, the facility is large, it takes a lot of energy to run that place, and you shouldn't just ignore it. So if you're going to put in a fitness center, don't ignore it. Same thing for the pharmacy. There is a pharmacy in our clinic in the support center. Make sure that you're managing the pharmacy. You cannot just walk away, and make sure you're getting the requisite data that's required. So really interesting stuff. We've reacted to this. When we first put in the gym, it was pretty expensive. It cost about $75 to join a month as a member, and then you could have a kick up to a service that would get you this extra special treatment. Don't quite know what it was. It was some special machine you got to get on, and it did things for you. But you got to buy up to this other service. Well, we started to see that, okay, that was great at the beginning, but people change. And long about 2015, we started to see some changes with the membership. Some of it because they were reacting to how they could get services other places cheaper, and some of it was just because, hey, I don't need that service anymore. So we worked with the fitness provider, and we said, you know what, let's just trash the old way, and now you can go to the fitness center for $25 a month. And if you go more than 10 times, it can be reduced to I think it's like $15 or $10 a month to compete with the Bally's of the world because that's what they're charging. So, and then the advanced service can get reductions as well if you participate. So there's incentives to go and maintain your membership on a regular basis in order to get a reduction in price. And so, and then we also introduced some coupons because some of the people from the outside of the company were saying, hey, I want to go to the fitness center. So they're able to buy coupons. And they can pay for those coupons and then just use the coupons every time they come. So there's some creative ways that you can think about it using the data that can support where you want to go in the direction you want to go. So a lot of different data, you'll have these slides. They just are really helpful in knowing whether or not programs are effective. We put in some of these programs and we just said, you know what, triple threat isn't working so much for us. Let's not invest our time there. It also showed us that there are some people who really would do these activities if they were more local to them. So there are times where the fitness instructor doesn't just do the activity in the gym. They'll go out to the location, because we have 17 buildings on campus. They'll go to one of the buildings and they'll say, okay, today we're going to have a Tai Chi session, and they'll just do a Tai Chi. We're also working on, we had some yoga that we're doing in the big fitness center space, and in the summer, they want to move the yoga to the outside yard, which I think would be kind of cool to see our CHRO doing Tai Chi in the morning. Everybody would feel better about HR if we were a little more flexible. Now, this is the big story. So that's the basic data you should get from the clinic provider. It can really help you manage and run and know if you're doing the right things around the clinic. But then you've got to look further, because you have to aggregate that data with your health plan and what's happening around your campus. And so we not only allow our team members to go to the on-site clinic in our locations, but we also allow them to go for $5 to any one of our operating clinics around the country in our stores, whether they're managed by another provider, such as here in Illinois with Advocate, or run by premise through us, or run by us through our healthcare clinic solution. It doesn't matter where they can find the solution. They can go for $5, and the claim is processed through our carrier. So Blue Cross Blue Shield, United Healthcare, they all process the claim for us through there so we can get the return. This all goes into a warehouse. All this data, the clinic data, all the information about cost avoidance is then aggregated together with what we know is happening in the space around us. So, for example, we've done a study that looked at if you had a clinic within 10 miles of your home location, did you use it? And if you did use it, what was the result? And if you didn't use it, is it costing us more in the health plan for you to not use the clinic? And what we found was that, yes, it's very true that clinic use actually drives savings. And we did this using our own data in our own data warehouse. And we just basically said, we bifurcated the group. And we took out all the other things that get in the way of the variables of studying the data. And we looked at whether or not you went to one of our clinics within 10 miles of your home or whether you didn't, and what services you had. And we just did a service comparison, so just taking acute sinusitis, 4,116 members for a total cost of $364, 7,800 services, cost per person is $46. We saved $128,000 for that service because when they were in non-K care clinics, the service fee cost $63.11 out in the community, even with negotiated fees. So you can kind of see that this really got a lot of visibility with our CFOs at the time because they were transitioning, and they really saw that there was tremendous value here. And so what you could see is that the upside is we were saving about $1.3 million, but we had the ability to save $1.7 million. So they said, how do we go after this? Because we want all these people for all these services going to the clinics. And so we did some mass advertising, and we put it on the back of the benefit card. So Blue Cross Blue Shield agreed to put healthcare clinic and where that you could pay $5 to go to a healthcare clinic, and that pushed some of these numbers over. And so we did the study again, and we found in 14 and 15 that we were shifting some of those services. Still hard to capture everybody. There are some people who just will not go see a colleague for care, and there are some people who are just not comfortable going to an on-site clinic in their own facility. There are some people who are actually shy to walk into an on-site clinic and have their other fellow members see that happen. And so we have to work on some of that information and that knowledge. But a lot of the data has helped us drive a lot of our decisions. And so I just wanted to show you some of the raw ways we did it. What we've also done is we've started to take in the clinic data from all of our clinic locations into our data warehouse, and we're taking in PTO and disability information and claims data, and we're going to be able to then use that now to even look further at productivity loss and productivity savings that, a la Wayne and other papers have said you should do. Now that we've got the CFO convinced that it saves money, he's now willing to say, well, let's look at other ways that it's bringing productivity solutions to the company, because he has seen it. There was one of our CEOs had some problems and was going to get on a flight and was thinking of canceling the flight, but he went to the clinic and he got the things he needed to get, and he still was able to make the flight. But if you think about the cost avoidance of that situation, had he done what he would have done, which was gone to an emergency unit or urgent care center, because he's from the UK, he probably would have never made his flight. He probably would have been gone from the office all day long. Even though he's salaried, his time away from the office, even though he has an iPhone, is a waste when he's not engaged. And if he would have missed his flight, British Airways doesn't refund unless you've died. So he would have lost all of that money, and we pay business class, so it's like $7,000 to fly to England. That's a waste of money. And so we're able to show these repeated advantages that we get out of this. One other case that we've used and we've shown with the data that we have is allergy shots. Think about simple allergy shots. Somebody needs to get allergy shots. Do you know how long it takes to get allergy shots? Has anybody have to get allergy shots? It takes all day long. You have to go there, you have to find the doctors, you got to get the time scheduled, and then you go there and you got to wait. You get your shots, and you got to wait some more, and your day's wasted. And do you come back to work? No. So we've now lost a whole day of productivity for a 2-hour allergy shot. Allergy shots can be done in the clinic, and they can take an hour. And the person goes in, gets their shots, waits a few minutes for reaction, and goes back to work. Simple. Just a simple example of the way that productivity can be impacted by managing stuff through a clinic. And we've shown that through the data, and it's been very helpful. So let me turn a little bit to telemedicine, because we have this massive population still that have no access to anything, because we don't have clinics in every store. I can't set up clinics everywhere for 33 people. And so how do we make it even more effective? And clinics don't operate 24/7. And I don't know many that do. If they do, good for you. I can't get mine to operate 24/7. Our support center doesn't operate 24/7. So what do you do for people who are traveling a lot, who don't have access to care, and who have challenges getting to that care at certain times of the day? You set up telemedicine. We have a great telemedicine relationship with MD Live. It started as a relationship that was for you, the consumer. You, the consumer, could go onto the Walgreens website and you could buy telemedicine services at a discount through our website with MD Live. And I said, why are we doing it for customers? We need to be doing it for team members. So we went to MD Live and we worked out a deal. And it is really simple. I don't pay anything. Well, I pay through the claim. Because MD Live processes all their services after a $5 copay through all of our carriers. So the $59 charge gets reduced to $54, and then it passes through Blue Cross Blue Shield, and I pay the claim as a self-insured employer. Simple. It was easy for us to set this up. The contract terms were very simple. Didn't need to go through procurement, which can be a real nightmare for employers. Then it becomes part of the health plan cost. And now I can aggregate that data more easily. We made it simple. Our team members are recognized when they go to our website, when they log in, because it already knows when you log in that you're a team member through our Balance Rewards program. And so when it does that, when you click on another button for MD Live, it automatically starts to register you as an employee, knowing that you get a $5 copay. So then once you've registered, you now have full access to MD Live through video chat or through phone chat any time of the day. And we have had one of the largest uptakes during implementation in 2016 that MD Live has ever seen. So our members really like this, and they really use it. It has augmented and supported the clinic services. And MD Live, if a person indicates that they work with one of our clinics, MD Live sends the data and the information to the clinic. So it's a kind of a enclosed, encapsulated service that allows us to extend a clinic environment to all of our members across the company 24/7. We've done tremendous amounts of advertising. We've just recently advertised a bunch of stuff for Houston and for Puerto Rico and for Florida because of all the hurricane mess. You can just imagine these people have care needs, and they cannot find a doctor. Good luck finding one who's underwater. MD Live has been there for every single one of our people, and they've been able to help them find prescription services through their strong network. So we've done a lot of advertising around this. We've had great feedback We don't get a lot of good feedback for benefits at Walgreens. I'll tell you, our benefits are pretty tough. It's hard to manage 250,000 people. But this kind of stuff, we had about 150 of these. This is awesome. This is one of the greatest things you've ever done. And our utilization shows that it is, because we have repeated visitors to the MD Live service. So we are taking that data now, and we're looking at it even more aggressively to see if we're really getting the aggressive ROI that we think we are getting. Roughly, we've paid for the MD Live program because they have a little PEPM that they charge us, very, very small. We've already paid for that 4 times over, just through cost avoidance, through estimated ER cost avoidance, urgent care avoidance, and primary care avoidance in the middle of the night. So it's been really good to see that. I can't share the data because MD Live told me it was proprietary, but if anybody wanted to see it, I can share it with you. It is pretty demonstrative, and we are pretty proud of the telemedicine program. So this is a way that you can kind of shell a whole program for an employee population that's pretty large that may not have access to services and situations for them. So hopefully this helps you a little bit. I'm happy to share even more if you'd like. We have a plethora of data. I just wanted to give you a touch of what we had so you could kind of see the avenues that we're looking at, just basic data for managing a healthcare clinic. Any questions?
Well, let's thank Tom. So, questions from the audience. So, Tom, where are the biggest challenges on the data? The integration of it, or how does that work?
Yeah, I think the biggest challenge is integration wasn't too bad of a problem. You find the right data warehouse vendor, and they're pretty good about this stuff. Most of it was the privacy stuff, dealing with the privacy issues for everybody who's involved, from the carriers to the providers to our own legal department that has a lot of worries about HIPAA privacy just because of who we are. So I think that's been the biggest challenge, and getting over some of those hurdles with the right BAAs that are necessary for people who don't know, that's business associate agreements or contracts that need to be in place.
Okay, questions?
Earlier, there was a question as to which vendor should you use, perhaps, for a service. When I was the global medical leader at General Electric, you wouldn't be surprised to know that twice a week I would have someone come to tell me about how they could save me $1 billion for my 350,000 workers worldwide. The question I normally asked them back was, are you doing what you want to do with my employees with your employees? And a terrific starting point, in my opinion, when you talk to any vendor who wants to do anything with your employees, is to ask them what they're doing with theirs. And I commend Tom on the wonderful things he's doing with his employees at Walgreens, and I encourage him to publish any data that he has that shows especially that you're bending the healthcare cost curve, that you are demonstrating that you're delivering on a culture of health for your 250,000. If enough employers do this around the country, we will solve the healthcare crisis in America. I'm confident of that.
Thank you.
Tom, we've talked a lot about how you can work with health plan data. A lot of employers, now a survey says over 60% do not charge anything for people, but some bill the plan for a zero amount just to have the data as part of that. How does it work for Walgreens?
So we actually require all of our clinical groups, even if it's in a store or with premise, they bill our plan. So if somebody comes in and presents a Blue Cross card, they collect the $5 copay, and they take the Blue Cross card and they file a claim just like it was any other provider. And so then I get the data, and I have the data, and I have the ability without any other feed to get the data and see the data. And I can actually compare how our on-site clinic is doing to our store clinics. Not allowed to share that here. But it's interesting. It's really been some really good data, and it's helped us drive some clinic decisions. But to us, that was the easiest and best way to capture the claims data and then also have it hit the plan in the right way. so that we were capturing the expense.
Okay. Any questions? If not, again, let's thank Tom Sondergaard.
Oh, and I do want to thank Larry for adjusting the schedule and for Vic for changing the schedule. I have to drive a long way to get to a wedding, so I appreciate you.
You're quite welcome. Safe drive. So we're going to take a break now. There is food, refreshment, and please, I want to thank and encourage you to visit our vendors, Premise Health, Marathon Health, Novo Nordisk, Freudent, and the College of Medical College of Wisconsin, Twine Health, and our resource table. I also want to remind you, in the upper right-hand corner of the agenda is the link so you can get all the website materials, the bios, the agenda. We encourage you to fill out the evaluation form as well. And for those who are members of NAWHC, there will also be a recording of these whole day that you'll be able to get a bit back for you. So let's take a break now and come back here in about at 15 minutes, let's say 10:55. We'll see you back here at 10:55. I got one technical glitch, but otherwise everything else is get them on flight.
Well, I'll have to ask you because I'll be recording you.
Walk as much as you want.
Then I could just give you the MasterCard and next time we go out, then you can pay it, right?
It'll be fine.
I was actually writing on my, and I brought that stuff over.
Yeah, so Oh, yeah, I've got a hard copy. I'm good. How are you, Tom? I'm on a need to take over the rest of mine. Like in the box.
Well, and to be honest, a lot of information from the VA.
Larry, good to see you again. Thank you very much for everything.
Very short view of it around.
We are,
Are you left-handed as well, by the way?
I am not.
Oh, well.
Yes.
So were they saying all the stuff like that day that they like operations center where all the nurses and doctors and that like that center? Yeah, that's
Make a left down the hall, they're over there.
yeah.
The other side. Well,
There you go. It is, yeah. And you sent hello to her.
she's doing well. We just see you too.
Okay.
And I know you know quite well enough not to listen to anything they tell you about me.
Yes, but why? Oh, yeah, that's what you know, yeah, everybody, that makes sense.